Okay, this is a young woman with nausea, vomiting, intolerance to food. And she had first a CT abdomen and pelvis. And at the time, we had noted that her SMA was a little acute. So here's the SMA right here, and the duodenum is right there. And we, one of the things that we had raised was possibly SMA syndrome. And she went on to get an upper GI. And the upper GI showed, so she drank and like there's nothing that passed for like 10 minutes. And so then they had her walk around, walk some more, and then come back. And then like she sat down and finally like a little bit passed. And this was a few years ago, a little bit, I mean, after like I think it was like 10 minutes and walking around.
Nelly, if you go back one image.
Yeah.
That's a nice one. Go forward one. That's a nice one where you just like, nope, the other way, right there, where you see like a linear cutoff, like right at the midline. And one of the techniques that supposedly is supposed to work, and has worked for me once, is like when they're lying down, you see that linear cutoff, but then when they sit up and the SMA like is off of the duodenum a little bit, it's supposed to release it, and like some contrast can go through.
Gotcha.
It sounds like in your case, even when she was walking around and stuff, it wasn't going through. So that's even more dramatic.
Yeah, we got a mesenteric angio, and I'm not going to show that because I just wanted to show any PHI in there. But I don't think we use ultrasound typically for SMA syndrome. So we said, like just this. So she came back a few years later to reevaluate. She's now GJ tube dependent because she's not able to keep down liquids and food. So then we got a repeat upper GI. This is 2 years later. And I did this, and so we first, like I had her sit up and she drank a barium, and it pulled and it didn't go anywhere. So I like brought her recumbent in a supine position, and then nothing happened. So then I rotated her to her right. So then when I rotated her to her right, that's when it started to empty. And it was when I spoke to her, she said that, it's exactly positional. Like she feels better when she's on her right side. And it was just a nice manifestation and imaging findings of SMA syndrome, I think, for me. And that cutoff sign, I was able to kind of, I saw, so I had, and then I went, like had her go back on her back, and I can, well, these are like later. So these images are kind of just, we have contrast in the downstream bowel, so it kind of obscures the findings. But I think the initial upper GI and this upper GI sort of still proves just the delayed emptying beyond the SMA as it crosses over. So one of the things that I learned from a colleague is, the renal vein also crosses between, like posterior to the SMA. And so patients can also get kind of compression of the renal vein as well. This is not, let me see if I can get it better. So in her case, this is the left renal vein here. The right renal vein is here. But so one of the things that we can potentially raise is a nutcracker syndrome. But with nutcracker syndrome, I think that you see more, or my colleague said she would look more for like gonadal vein distension, like lumbar vein distension and stuff like that, like secondary findings of essentially venous obstruction. And I didn't really quite appreciate that as well on this patient. So I kind of let that go.
Cool. Yeah, SMA syndrome is a mystery. I have 2 questions for you. One, how come they haven't done surgery? You said she was like GJ dependent. Like I know sometimes they can do a duodenojejunectomy to divert.
I think they had wanted the ultrasound to be concordant with the cross-sectional imaging and upper GI, and it wasn't because the
Okay.
flow.
Oh, so they did like some kind of ultrasound and measured some flows and said it wasn't concordant with SMA syndrome.
Well, we didn't say it wasn't. What we said was that ultrasound it does not evaluate SMA syndrome as well as functional studies like upper GI.
Yeah, I don't know.
So it wasn't
but
quite discordant. I don't think kind of sort of like my limited understanding is that, like they just wanted all the stars align before they took this patient to, potentially a significant surgery.
Got it. And then your second fluoro study, I was thinking also in the differential could just be gastroparesis. It sounds like between the two fluoro studies, you guys were pretty convinced, but sometimes like when the stomach is super distended like that and you need to put them right lateral to get it out, sometimes it's gastroparesis too.
We got a nuke bed study.
Yeah.
Yeah, gastric emptying. And I want to show you, but it's got patient on it. I think it was normal. Like, I don't think it was.
Yeah.
I'm trying to look for the report, but I think they ruled it off.
Okay.
Okay. So I'm going to kind of lead you through this one because there are a lot of findings, but I think the end diagnosis is pretty cool. So as I start here on the coronal T2 haste, just want to.
Can you double click when you go through
the
sequences?
You like that? So
yeah, it blows up. Yep, perfect.
Yeah. So do the kidneys strike anybody? Yeah, exactly. So first we see that the kidneys are abnormal. And now I want to go down.
They're big.
Yeah, so they're big. And then here's our out of phase. And then once you pay attention to the cortex here on the right kidney, then I'm going to come to the in phase.
Like NPH or something.
Yeah, so we're losing some signal, right, between the out of phase and in phase, right? So then coming back here to the coronal T2, this really dark structure in the left upper quadrant is not the stomach because that's here.
Or hemolysis.
Yeah, so yeah,
or
so we have a dark,
hemosiderosis.
so we have a dark spleen and then dark renal cortices. And then we'll come here to the axial T2. There's a little motion, but they've had a cholecystectomy. They have all this bile duct dilation. They have a stone there and a stone here. And I'm going to come to the T1 pre-contrast.
Sickle cell?
Yeah.
Oh, good job.
Isn't that crazy?
Shenoy-Bhangle got it too.
Yeah, like in all of my training where we've had like high sickle cell population, I've never seen so many manifestations in a patient. But yeah, so we have the small calcified spleen, we have the renal cortical hemosiderosis, and then we have pigmented gallstones. And so, yeah, the constellation of findings is in keeping with sickle cell. The one thing that I will say I was a little disappointed that I didn't have were the fish mouth vertebrae. But other than that, great job.
Cool. I know for the renal iron deposition, paroxysmal nocturnal hemoglobinuria, isn't it? What did you say, Nelly? You said something like NRH.
I might have said the wrong acronym.
Oh, okay.
But I thought it was like N. It's like, isn't it N something H nocturnal NPH or
NH?
Yeah, in my mind, I was thinking nocturnal paroxysmal, like hemolysis, or yeah.
Yeah, some combination of those words.
I knew exactly where you were going.
Cool, very cool case. Yeah. Okay, Nelly, back to you.
The patient who is being evaluated for renal donor eval. So renal donor eval. So we did our usual renal donor eval multiphasic CT, and the patient had this kind of dilated, it's sort of just cystic stuff in the pelvis, renal hilum, and so that's a really nice thing about the expiratory phase because you can kind of differentiate what from what. And there's cysts. Cysts that herniate into the renal pelvis. And in addition, there's also dilated calyx upper pole.
I feel like you told us a syndrome, like Fraley syndrome.
Yes, we did. Yes, exactly. So when we look at the arterial phase, the Fraley syndrome is when you have compression of the infundibulum from like a crossing vessel. So on the arterial phase, we have the renal artery that bifurcates into the segmental arteries, and the artery that goes to the upper pole crosses over the infundibulum in the upper pole calyx, and then causes that to become dilated. So then you have this, and that's what happened here. So this calyx here is dilated from that crossing vessel, and that's called Fraley syndrome. Sometimes it can cause hematuria.
The sad thing in this case is that Fraley syndrome is probably going to prevent this person from being a donor.
It may, yeah.
Because I know that even if they have like cysts and stuff, that can preclude. I think they have some criteria. So if they have like focal hydra like that, I think they would probably not donate that. And usually they take the left kidney because it has a longer pedicle. Okay, next is a new
adult coming in with abdominal pain and swelling, and how many times is an ultrasound abdomen positive with this kind of a history, diffuse abdominal pain and swelling? So the tech was very astute. Here is the right kidney going on to the left side. The spleen looks okay. And then this is the lower pole of the left kidney. Here is the left kidney in SAG. And then they notice this finding. So this has been labeled as SAG, left upper quadrant. And this is a lesion or a mass that sits between the spleen and the left kidney. And there are some areas of calcification within it. It's a fairly large mass. And it looks like from the ultrasound, it resides in the area of the left adrenal gland. Let me see if I have a cine sequence here. Yeah, so this is the cine through the mass. It looks very much like the spleen, but we've seen the spleen as separate, and here is the left kidney. So sure enough, the next test would be cross-sectional imaging, either CT or MR, and they were sent for an MRI. And I'm going to start showing you the MR images.
Wait, so did we think it was from the adrenal?
Yes, indeed. So we thought that this was a mass arising from the adrenal gland. And given the size of the left adrenal mass, you can see which direction this is going. So let's start with the in and out of phase. So here is the adrenal mass, out of phase sequences, and in phase sequences. So as you can see, there are some intrinsic T1 hyperintense foci within this lesion, but no drop in signal to suggest presence of fat. This is what it looks like on T2 weighted images. It's not super bright. It is bright, but fairly pretty heterogeneous. And this is the coronal T2 weighted sequence, where again, you can see that it's separate from the kidney, pushes the kidney left kidney inferiorly, heterogeneous on T2 weighted images, some T2 dark signal within it, which is, this is the other kidney with corresponding intrinsic T1 bright foci within it, suggestive of areas of hemorrhage. And then this is what it looks like on post-contrast sequences. So, sorry about that. Okay, here we go. So heterogeneously enhancing on the post-contrast sequences. So differentials for a large adrenal mass. And then by this time, between the ultrasound and MRI, they get additional endocrine workup as well. Prodding deeper into the history, there is a history of headaches. And there was one episode of presenting to the ER with stroke-like symptoms. And at that time, they found markedly elevated blood pressure as well. And they are relatively young. So any differentials for a solitary large adrenal mass with these symptoms, and I shall give you the endocrine workup later. So any adrenal mass larger than 5 centimeters in size.
ACC, pheo. So the calcification is more common in ACC, like it looked like on the ultrasound there's calcification.
Correct.
Both can cause hypertension because ACC can secrete cortisol, but pheo causes usually more severe hypertension because of the metanephrines.
Yes, exactly. And do you see any other finding on this particular
The
image on the
vein.
post-contrast?
There's like tumor
Yes,
invasion.
bingo, Nelly. Yes. So there is, as you can see here across the midline, there is a tumor thrombus from the adrenal vein going into the IVC. So, based on their symptoms, initially, I was thinking this might be a malignant pheo, or of course, ACC because of the calcifications, as you mentioned rightly, Aarti. And then they operated on this. This turned out to be an ACC. I was looking at, are there any MR features that can help us distinguish one from the other? And there are not. They say calcification is more common in adrenocortical carcinoma, but if you go by pure MR sequences, both can show necrosis, hemorrhage. They can both be very heterogeneous. And then any adrenal mass larger than 5 centimeters is considered malignant unless proven otherwise. And of course, there was a tumor thrombus extending into the vein as well. So in terms of their endocrine workup, they did not have elevated metanephrines. And so pheo was already out based on the endocrine workup, but they did have hypercortisolism and increased DHEA, so hyperandrogenism kind of. And on, when I read the note, there were clinical manifestations, hirsutism and weight gain and other manifestations of increased cortisol as well. So that's that.
Very cool. I have one comment. I used to think that, this venous invasion, and it still is more common in ACCs, but I actually just presented a case here a couple of weeks ago of like a large lesion that was invading the IVC, and it turned out to be a pheo.
Pheo. Yeah, so actually my first differential for this was a pheo, based on all other things, and the endocrine was not up then, but turned out to be this.
I think the venous invasion is still much more common in ACC.
And the calcification, as you said.
Yeah.
All right, so I'm going to pull up the second one if you want to. So this is an adult patient. Commonly, we see this finding in the pediatric age group, but the history they came in was recurrent UTIs. And let me go through the VCUG. Okay, so here is the scout. Hold on. This way, this is the first image. Here is the scout. So that's the Foley, the bladder is being filled, and then they start voiding. It's very difficult in women, I've noticed, to keep the Foley in and have them void. So invariably, once the bladder is fully distended, if they're not able to void around it, I kind of take the Foley out. They were not able to void lying down, so then we had them stand up and oblique. And as you can see, and because this was left-sided recurrent UTI, we positioned them such so that we can demonstrate the left ureter better if there is reflux. And as you can see, there is something that is filling up. As they keep voiding, the column of contrast that extends cranially keeps going up. And here you see contrast opacifying the collecting system or the renal pelvis, and the entire left ureter, even after the bladder is completely empty, is opacified. And actually, when we went back and looked carefully at where this ureter inserts, you can see that it goes down and inserts into the urethra. So interestingly, when we went back and looked at their outside CTs, I'm going to show you first a non-contrast CT.
I'm sorry, you said this is a man or a woman?
Woman.
Okay.
This is a woman. Yeah. Okay. So, so from the VCUG, we know that there is reflux and that this ureter inserts ectopically into the urethra. Okay.
And she's not like she's continent, urinary continent.
She is continent. She was continent. The only complaint she came in with was recurrent UTIs. And apparently she was investigated as a child, but then due to some economic and financial issues, it went unnoticed. And they moved countries, and now she presented to us, to a urologist here. So I'm just quickly going to scroll through a non-contrast CT that she had in her, on our PAC system from 2015. And on this non-con, if you go through the axials and the coronals, you see the left kidney, not given contrast. We don't see anything spectacular. But then I'm going to show you a
There's
a
like
contrast.
some atrophy and like there was some cystic thing in the upper pole of the left kidney. Like, is that like a second moiety that's
You are too sharp. I thought I would show you that finding more on the post contrast, but maybe it's the shortage of contrast, Aarti, that has sharpened your. Okay.
Yes, I'm very paranoid now.
See, no, you're absolutely spot on. So on the post contrast images, you can see that there is a cystic structure up there. You know, automatically you're thinking of the Weigert-Meyer rule and looking for a duplex moiety with this kind of VCUG finding. So indeed, she has an atrophic upper pole and a normal, almost normal appearing lower pole. But the interesting part is, you know, according to the Weigert-Meyer law, it's usually the upper pole that is ectopic, obstructed, and atrophic. So here, this is atrophic, but on the delayed phase, unfortunately, the delayed phase, this is an outside CT, the delayed phase stops short and it doesn't really go down all the way. But on the initial phase, you can follow the ureter. Hold on, let me. Here. You can follow this ureter, and this ureter actually joins the lower pole moiety, but this ureter is ectopic and inserts into the urethra. So this kidney doesn't really follow the Weigert-Meyer law, or maybe it follows somewhat, wherein the upper pole is atrophic, but the ureter, we can't trace that ureter, and the lower pole ureter you can trace, and it looks like that one, the lower pole is ectopically inserted into the urethra and refluxing as well. So I thought that was interesting.
So like one of the ways that I had, so the upper, so vowel upper obstructs, so UO, like up vowel, or no, and then lower pole reflux. That's how, and this one, and the upper pole obstructs usually from like a ureteral seal.
That's
or
correct.
something like that, right?
Yeah, so the upper pole is set to insert ectopically and very commonly ends in a ureteral seal. Therefore, it obstructs, and over a period of time, the upper pole atrophies. Whereas the lower pole has orthotopic insertion, but it refluxes. Here, the lower pole is ectopic, but it refluxes. And we couldn't trace the upper pole ureter because that moiety is very atrophic now, non-functional.
Nelly, I like your technique because upper obstructs and is ectopic. So all three of those are vowels.
Oh, good point.
Makes complete sense.
Ectopic, yeah.
Okay.
Okay.
And then I have,
sorry. Oh yeah, go ahead. No,
one
go ahead.
last one. Okay, perfect. Again, starting with a VCUG. When I show you this VCUG, you'll know what the history is. So I won't give you the history up front. Scout image. There are multiple phleboliths in the pelvis. This is the filling phase. And you start to see the finding. Any guesses?
Intraperitoneal rupture. Why do you need a VCUG though? Like,
So
we saw that on the.
exactly. Yeah, no, the CT was done afterwards. And again, you might ask, why do you need a CT? So one or the other is enough, right? So this is iatrogenic post hysterectomy. They had sent for a VCUG first, and the VCUG appropriately demonstrates the findings. You have leak of contrast, and the contrast opacifies small bowel loops in the pelvis. So indeed, this is intraperitoneal rupture. But then they went ahead and got a CT for some reason. I don't know why a CT was necessary, but I just thought, usually we do this, we look for intra or extraperitoneal rupture, and based on the history, you kind of anticipate, like if there is a history of blunt trauma, then you might go one way, whereas if this is an iatrogenic injury to the bladder, then you might think of more of intraperitoneal rupture. But what I had forgotten was there are 5 types of bladder injuries, apparently. One is a contusion where the VCUG would be normal. 2 is an intraperitoneal rupture. 3 is interstitial. This is a very rare kind of injury. 4 is extraperitoneal, and 5 is a combined intra or extra. I've never used this classification. We always look for intra or extraperitoneal rupture because intra, you want to send them to surgery, whereas extra is treated conservatively. So I just thought, let's go back to the basics for this. Yeah.
Great
That's all.
case.
I can stop sharing.
Excellent. Okay, Nelly, back to you. And then after that will be Swachchhanda.
Okay. This is similar to Jonathan's case, or just series of findings that lead up to a common diagnosis. So this is a scrotal ultrasound. So we have this kind of cystic, solid extratesticular lesion. I'm going to be just careful not to scroll too much on the ultrasound images so that I don't expose any unnecessary PHI. Patient had a prior left orchiectomy, and then this was the MR correlate to that solid cystic extratesticular lesion right there. And then patient has multiple additional imaging studies, including this.
Some look like they have fat in them.
Let me see if I can do it. We have MRs. We can.
Yeah, I
look at
think
that.
Swachchhanda is on the right track. He's asking about
Yep.
VHL.
Yes,
thinking
yeah.
about papillary cystadenoma of the epididymis and RCCs.
That's right. And there's more. And then the pancreas, what did you say with the pancreas was?
I said papillary cystadenoma of the epididymis, but show me
Oh,
the
okay.
pancreas.
Sorry, we didn't mention the. Okay, got it. Let me show you the pancreas.
Pancreas, usually they get like serous cystadenomas, neuroendocrine tumors. Ooh,
That's a big one.
Yes. So this was a neuroendocrine tumor, bilateral RCCs. It does look fatty, but all of these underwent partial nephrectomies and they came back clear cell. So I don't know if it's intralesional fat and it just looks more hypodense and make it kind of look like macroscopic fat, but they were all clear cell RCC. And then I think I showed the spine, but
I think the hypodensity is actually the VHL clear cell RCCs tend to be like have a lot of T2 hyperintense, like fluid in them.
Fluid, yeah.
Gotcha. Okay. And then there's your hemangioblastomas.
Wow,
the spinal
that's
canal.
yeah. That's a subtle.
Yes, and that extratesticular lesion with this is the left side they resected, the right side they're monitoring cystadenoma.
Very
Very
nice.
cool. Great job, Swachchhanda. Okay, I think, yeah, Swachchhanda, you're up.
Sure. Let me push. Is it on pause? Okay. So this is a very simple case, but the discussion, I'd like to get your opinion. How do you approach with the diagnosis? So this is 35-year female, and obviously we see something is wrong here, an extra mass in the abdominal pelvic region, which is pretty heterogeneous on T2, and again, no suspense, but this is coming from the uterus. So it's, for example, here we can see the endometrial lining. We can see it better on axial as well. Let's see. Okay. So here you can see the cervical canal and extending to the endometrial canal. And from this area, we can see this large lesion is arising. But now, since the patient is just 35 and if she wants to preserve the fertility, so the question would be, can we separate whether it is a degenerated fibroid versus leiomyosarcoma? So that was a question the clinicians are asking us.
Swachchhanda, I have a quick question. Can you show the T1 pre? I just want to see if there's
sure.
any hemorrhage in it.
Oh yeah, so this is the T1 pre. There's no significant, maybe we can, but nothing significant T1 brightness. Little bit here. And if we look at the margin, so margin is pretty smooth, except there's a little bit of bulge on this area, left lower. And post contrast, obviously we see this mostly intensely enhancing with multiple areas of non-enhancing area, which is not unexpected in this large lesion. And obviously, apart from that, there is no any extra lesional or like extra uterine extension, gross extension. There is no hydronephrosis. And we didn't do diffusion, but I don't think that would be super helpful again. So if the clinician asks, can we rule out leiomyosarcoma? So what should be our answer?
I think
It's in the
very
differential.
hard. Yeah, it's very hard to distinguish if there is no invasion. I mean, from what I read in the literature, if there is invasion outside the uterus, that's the only way you can tell. But otherwise, if it's contained in the uterus, it's very hard to distinguish. But correct me if I'm wrong, and diffusion doesn't help.
The Fiona's paper, didn't she say something about that finger-like projection that you saw?
Yeah, let me show
showed?
you. Actually, I have her paper up. I have a
Yeah,
companion link for this.
and like that finger-like projection, that thing right there in the left lateral border, that is one of the features of leiomyosarcoma.
Yeah, I don't like that border. Let me show
Yeah.
you my screen. Is that cool?
Go for it.
Okay.
So actually, I was like reading about it, and
Definitive.
Oh.
You can get intravascular invasion of the benign.
Yeah, leiomyoma as well.
Yes.
With
Yeah.
long-
But those
long
are usually like
metastasis as well.
leiomyomatosis, and this one is like one solid lesion. Is that right?
Yeah, it's just single. So there are several points that might little bit tilt us toward sarcoma compared to benign lesion. But since we know that leiomyosarcoma is so rare compared to the leiomyoma, so I think, leiomyosarcoma. So as they say, the uncommon manifestation of common disease is way more common than common manifestation of uncommon disease, right? So even without looking at the image, if somebody asks whether it's like leiomyoma degenerated versus sarcoma, I'm gonna say it's most likely degenerated leiomyoma. And like the others, some features might help to tilt the balance a little bit, but still, whatever features except like gross extrauterine invasion, I don't think we would be able to tell the difference, or we might be able to differentiate. For example, age. So this patient is just 35, so it makes sarcoma to be pretty rare. And since it is solitary, that might tilt because we know the sarcoma is solitary, and like the myomas can be multiple. So if it is solitary and large like this, then it might tilt us little bit more towards sarcoma, and the heterogeneous appearance and like T1 hyperintensity and this nodular contour, those might also tilt a little bit towards the sarcoma. Restricted diffusion, heterogeneous enhancement, anything. But again, for example, and also I saw a couple of papers which talk about like multiparametric analysis, finding the the difference between the signal intensity of the leiomyoma compared to the the uterine myometrium, and then getting some weird ratios, but I think overall, since leiomyoma are so common, and given this big size, the degeneration is so much more common. So I think best bet would be still degenerated leiomyoma, but also we know that there was such a big like fiasco in somewhere in like 2014, I suppose, when the critical care physician from BIC was like thought it was just myoma, and then they morcellated, and ultimately it resulted into disseminated leiomyosarcomatosis of the peritoneum. So like given all those things, I think what I personally would do as a resident or as a fellow would be most likely representing degenerated leiomyoma. However, given this concern, for example, large size is single in number, and then with that nodular contour and heterogeneous appearance, leiomyosarcoma cannot be excluded, like just to make ourselves on the safer side. So yeah, that's my thought process.
That was
That's good.
excellent. I just wanted to show this was Fiona's paper, and these are the 7. They looked at 15 different factors, and these were the 7 they said were the most important, and they have two kind of helpful charts here, but as you're saying, like we still don't have, this is not 100%, but hyperintensity is one of them. So like if it's hypointense, you can feel confident it's just a fibroid. And then the other thing I thought was interesting is the least important one was actually the ill-defined border, which is something that we've been talking more about for a while.
Yeah. Mm-hmm.
And then I also thought this was interesting. If it's hyperintense and it has hemorrhage in it, then it's most likely a leiomyosarcoma. So I thought that was interesting.
Let's do the flow chart for this case. So it was yes, hemorrhage. I didn't see hemorrhage. There wasn't any T1 hyper, so that's no. Necrosis. Would use those cystic stuff? Would those be considered necrosis? I don't know. Maybe they just outgrew their supply. Vascular supply.
I know that's hard. That's a hard one. But if we
let's
said
just
yes,
say
then it actually comes down to the ill-defined border.
And
yes.
Yeah.
And if it's yes, then it says LMS.
I have a lot of problems with this paper. A lot of problems. And unfortunately, we've been citing this paper so many times because I've gone through many cases, and it always like gives me leiomyosarcoma. And as Swachchhanda suggests, like raise, right? The PPV, what is your PPV? I don't think all of my cases are like sarcomas.
So
Swachchhanda, do you have path?
Yeah. Do you have follow-up on this case?
Oh yeah, actually they resected the whole thing. Like patient is 35, but patient underwent total abdominal hysterectomy with bilateral salping oophorectomy for some reason.
It
was leiomyoma.
Oh my
it was
God.
a fibroid.
Fibroid.
Jeez.
So going back to that chart, I guess the well-defined holds necrosis. Do they give us examples on this paper showing how much % necrosis? Like, is this small amount or large amount or?
Non-enhancing necrosis. This is what they call necrosis. This looks like necrosis more than those spaces that we had. And then actually going back to that, so say we said there was no necrosis.
Yeah.
And no necrosis.
So then it's 100% sarcoma. So any small amount of necrosis is yes necrosis, I guess.
I don't know, man.
I
Okay.
feel like this paper make us overcall so many fibroids. And I don't know. This paper doesn't settle well with me. The more I reference it and the more I read it, the more I'm like, we need more studies.
Great. What are the sample size? Sorry.
Prospective study now. Sorry, go ahead.
Sorry, what is the sample size of the sarcoma cases in that paper?
People keep asking me this. It's not very big.
Yeah, we need more.
They have 25 fibroids and 19 leiomyosarcomas. So like 44 patients.
But that's not enough leiomyomas.
Yeah. And they didn't even pick the really atypical ones. I think they just picked they sort of tried to match them or something.
I mean, because in reality, you're going to get 1,000 leiomyomas for one.
You're so right, Steve.
Yeah.
Yeah, they need to incorporate the prevalence. Yeah.
Yeah. Cool. Okay, Nelly, back to you.
Okay. This is an acute finding. Okay. So patient came in with recurrent pancreatitis and had peripancreatic fluid collection that we've been monitoring. And so we got an MR, and I'm showing you the study to look specifically at the kidneys, incidental findings.
And the medication they are on is
yes. What?
And the medication they're on is -- like lithium. Open to the crowd.
Yes, that's right. Yeah, this patient has a history of bipolar and had been on chronic lithium. So this is just a really nice example of lithium toxicity. We get little punctate T2 hyperintensive throughout the kidneys, and then on ultrasound, it's hyperechoic, a little small hypoechoic dots all over the kidneys bilaterally.
Super
nice case.
Yeah. Is there iron in that liver? I have a
Is
companion.
there iron?
Yes.
I wouldn't say there is. I use the psoas as my reference,
Yes, yes.
and I would call it if it's like less than the psoas.
Yeah. Doesn't look like. Nice. Cute.
Okay, Swachchhanda.
Sure. So this is 82-year patient. So what do you think about this case? What might be the diagnosis? Just looking at one image.
Giant cystadenoma of the prostate, of the seminal vesicle.
Oh, okay. You found out it's a male, right? I was
Yes.
trying to trick you to another fibroid.
You cannot trick Aarti.
You have to, then you
And
have to explain the polypoid lesion from the anterior part.
yeah, here also you can see the penis as well. And
Yeah.
here we can see the prostate. So basically, so this is 82-year male, and patient had, a little bit borderline PSA. So that's why patient was sent for prostate MRI. And I would say this is a coincidental finding. Here we can see this large mass. And obviously this is a male patient. So we are not thinking about uterine fibroid or uterine sarcoma. So this is the axial image. Again, we can see pushing bladder anteriorly, seminal vesicles on both sides, and prostate is here. So prostate as such didn't look bad. A little bit of this diffuse hypointensity, and here this area showed a little bit of restricted diffusion, but I'm not going to show more images of the prostate because I'm going to focus on this lesion. So what
Solitary fibrous tumor.
So we think it's like, I mean, the other thing that I was thinking was a stump tumor, I think, which is that it? The stromal tumor of, but I think maybe is it just more too heterogeneous? Is that why you said cystadenoma?
So here we can see the restricted diffusion. Again, that's not super helpful. And post contrast, we can see it is enhancing heterogeneously, mainly peripherally, but nothing much in the center. And this soft fraction, this pre-contrast T1 and no significant intrinsic T1 brightness. So the question is, before going to the histology, so where it is arising from?
Yeah, I've changed my mind. I don't think it's arising from the prostate or seminal vesicle. I think it's just like a pelvic tumor of not arising from anything.
So we can see the seminal vesicle here separately. It's compressing, but it looks roughly okay. And prostate is everting very little. Obviously, some lesions can arise from the periprostatic soft tissue, but obviously it's not arising from the prostatic parenchyma as such because it is so little abutment.
And I don't think it's a rectal gist.
Why do you say that?
I contemplated it, but I feel like the T2 looks different to me than most gists.
Yeah, it's too heterogeneous, right? I guess they can undergo necrosis and look like that.
It can definitely have central necrosis, but I don't
Yeah.
know, something about the inside of it doesn't look like a gist to me, but I would look to see if I could see it connected to the rectum. It's so big, it's hard to tell. I guess that's in the differential.
Plus, with this size, it would be hard to tell where it's arising from. We know it's like displacing everything, but can we be sure it's arising from one particular organ? It's too large now.
Yeah, I think that's one of the teaching points. When something is this big, and then it's really difficult to identify the organ of origin. Even the claw sign, it could be false positive.
Right. Yeah.
But the best bet here would be, since it is, like posterior to bladder and then anterior to the rectum, superior to the prostate, and, like below this pelvic inlet. So, and here, at least in this image, we can see.
Yeah,
this
there's
is
phlevoids coming from the rectum.
Rectum, yeah, phlevoid coming from the rectum in a little
It's
bit
like
of
a bridge.
sign.
Yeah.
Claw sign. So maybe some rectal mesenchymal tumors arising from the rectum. So it could be like gist or some kind of stump, or I don't know, some weird neoplasm. So they biopsied it initially, and since, as we can see, there is so much non-enhancing area, it came out to be inadequate sample, some necrosis or something. And since the patient was not willing to undergo surgery, also the thought process was if it exists, then it is so much amenable to treatment with Gleevec or imatinib. So they re-biopsied the lesion from the transrectal approach, since here we could see this thing. So, and probably the second time they got the better specimen, and the final diagnosis from path was malignant spindle cell neoplasm. And it was positive for SMA, which is smooth muscle actin, but it was negative for CD117. So yeah, so that's the
So wait,
diagnosis.
what does that mean? Is it a
So was
gist?
it a malignant
No.
gist?
No,
Oh, some
So
other kind of spindle cell.
yeah.
yeah, some weird, I think they might be cousins, but like not exactly the malignant gist. And it's CD117 negative as well. And SMA positive, it's kind of non-specific. It is smooth muscle actin. So, like it's that's positive for lesions arising from the myoepithelial layer. As we know, there's like mucosa, submucosa, right? So even in the mucosa, there is a muscle layer, which is called muscularis mucosa. So it has that some component. So obviously the mesenchymal portion rather than the epithelial portion or carcinoma. So some weird tumor, yeah.
Did they resect it?
Report cases of
No, they planned for resection, because since this is so big, they thought the patient would need abdominal perineal resection. But since the patient is 82 years, and then he said, no, he's not gonna undergo surgery. So it's, and now since it is CD117 negative, so they can't do imatinib as well. So I think they're just waiting what to do next. The good thing is, though it's malignant, maybe it's like low malignant, like low grade malignancy, because by the time it's so big, there's no mets or like anything aggressive adjacent to it.
It does look a little bit mass effect on the left ureter though. That's probably not
Definitely
causing
on
any
the
problem.
bladder, like you'd have to pee a lot.
Yeah.
Yeah.
Yeah, actually this patient already now, this was done like few months ago, but now the patient has a bilateral nephrostomy tube. So yeah, that makes totally sense. It has some mass effect in the bilateral ureters.
Ureters, yeah.
Very cool. I do know that there's new targeted therapies for just tumors that have all the other mutations. There's like a lot of different 15 other mutations that they can have. So there are trials for that.
Nice
Cool.
cases.
Okay, Nelly.
So the patient initially presented to us with this finding. Any thoughts on differential?
Cystic pancreatic lesion, all the differentials, age, based on age, gender.
Mm-hmm.
And is there a history of pancreatitis? I feel like I see some
No.
fluid. Oh, okay.
I don't think so, but I'm not sure. Let's just say no.
I feel like it has like a rind, an enhancing rind to it, which makes me think of a cystic neuroendocrine tumor.
Good. So then here we got an MR. Here's our T2. And then here's the post.
Oh, it looked like there was fluid around the pancreatic head, no? On T2. Maybe I've seen something.
Yeah, I think there is a component of pancreatitis now.
Yeah.
Yeah.
I'm still thinking neuroendocrine. It doesn't look like a serous cystadenoma. It doesn't have like capsule in the tail for mucinous. Doesn't look tubular for IPMN.
Yeah. Diffusions. Is there anything on diffusion that is helpful?
Diffusion. Let me show you diffusion. Where is
But
diffusion?
purely cystic neuroendocrine may not show, may show shine through and not.
Yeah, this is like a really old study, so we don't have a diffusion. Sorry.
Okay. No worries.
And then I want to show you. Where is it? She got a.
And the main duct is not dilated. This is like no obstruction to the main duct.
Main duct did not look dilated. But let's double check. Yeah, so this was resected. She underwent a Whipple, and it was cystic neuroendocrine tumor. And as Arthi astutely noted, that rind of enhancement
And then
is
also the smudgy enhancement internally. Those are two.
yes. So that rim of enhancement and then the smudgy enhancement. I don't. It's hard to see on the smudgy enhancement on the CT, but maybe better appreciated on the MR are telltale signs of cystic neuroendocrine tumor over other cystic pancreatic lesions, as others have said, like with IPMN or even MCNs. And cystic neuroendocrine tumor, there's like a genetic association with like MEN syndrome. So this is.
And they have better prognosis than solid. Okay, Swachchhanda, you have one more?
Case. But since I thought as an abdominal radiologist, we'll be doing chest as well because they scan chest, abdomen, pelvis. So, also, we need to take a look at some of the urgent findings. So this was a study done for TAVR, transcatheter aortic valve replacement. And do you see anything that needs urgent phone call in these images?
Why is that left atrial appendage opacifying?
Yeah.
When was it placed?
Sorry, this thing?
Uh-huh. Yeah,
Oh,
why is there contrast in the appendage when there's a
yeah.
watchman present?
Yeah, the Watchman device is here. And the contrast is going across it. So you're right. So we see anything else?
No, that was the first thing that caught me.
SVC and yeah, it's very heterogeneously enhancing, but is it like delayed contrast, just contrast admixture, or is there something in there?
Yeah, so that's the question. Yeah. So when we see this, so what should we do next? Do we make a phone call?
Well, so first you want to know when it was placed. You need a time frame because endothelialization can take like a couple months to occur. So you can still have persistent opacification after immediate placement.
Wait, what's at the end of the appendage? Is there like a thrombus at the end of it?
This?
Yeah.
Yeah.
Okay.
So what do we do now?
So do you know when it was placed?
Oh, it was 6 months ago or something, or even earlier.
Okay, so we're beyond, so it should have endothelialized. Yeah, so you should probably call them because it's not going to be effective, obviously.
And the patient's at risk for stroke.
Correct.
Yeah, actually in our center, these TAVRs, when they are done outside of the clinical hours, they usually wait for the final read. We don't dictate it. We just look at the really important findings which need immediate phone call. And this finding was missed. Obviously this was missed, but again, this would not be of major immediate concern, I suppose. Obviously it has to be fixed, but this finding was missed. However,
is there a delayed phase on this to prove it's a thrombus and not just slow perfusion?
Exactly. Yeah, that's the teaching point. So this was the delayed image, which is obviously not good because of the timing. But here we can see, maybe I can put both side by side. So
yeah, it's not a thrombus. Cool.
Yeah, not a thrombus. So that will obviously, prevent the patient or from getting a TE or like all unnecessary workup. So as our attending say, we have to look at all the images, each and every images. So yeah, so this was a pseudothrombus.
Is it typical for TAVR studies to get a delayed?
No.
Yeah, at least in ours, we get delayed.
Is it because of that? Like you guys want to clear the appendages?
That's a tough question. Actually, I don't know exactly what is
it. Because there are a few reasons. Like that's obviously one, but it depends on if your cardiologists really want to know on the TAVR study. There's also research at some centers doing extracellular volume calculations on TAVR examinations to then measure how well the patients do afterwards. So there are a few reasons, but it's not, as far as I'm aware, a standard practice to get a delay on a TAVR.
Cool. Great job, Jonathan and Swachchhanda and everyone. It's 3 now, so we're going to close it out for today, but have a great week, everyone.
Yep. Thank
Thank
you.
you.
Have a
You
good
too.
one. Thank you.